Yeah, so this is a new, I presented this first at the IMS meeting, but a new ADC that differs from the previous clinically evaluated ADCs like Belantamab, mafodotin, in respect to the payload, because it has, as I said, the amanitin as a payload, which has a completely different mode of action, because it does not depend on proliferation of the cells. It shuts down basically transcription of genes in general. And so it is very effective also in resting cells, for example, as we have shown also preclinically. And the phase 1 now is in dose escalation. We have gone up to 100 microgram per kilogram so far. And in the highest dose cohort, we saw like a 50% response rate, and we saw CRs. For example, in one patient, a CR after 9 prior lines of therapy, including CAR T-cell therapy and bispecific antibodies, and an ongoing CR in month, I think, 15 now. So, of course, dose escalation is ongoing, and dose schedule optimization is ongoing. Why? Because we saw in the highest dose cohort, we saw several transient, rapid declining, but rapid re-increasing thrombocytopenias. But I should phrase it differently. So the thrombocyte levels decreased rapidly after the first infusion, but came back to acceptable ranges quite early. So the mechanism is not entirely clear, but that led to a different approach in terms of dose scheduling. So from every 3 week that we split dose, for example, in 2 initial doses, or we split to a weekly dosing and so on, which is now ongoing. And so what we see so far, it looks like this can mitigate this initial platelet drop, so that the dose escalation as of now, after the ASH meeting, actually is now ongoing with higher doses. And let's see what kind of response rates we will get there. As I said, the initial data look very, very promising as a single agent in late line patients, with even achieving CR in some patients.